today is titled Coping with Acute Myeloid Leukemia, Strategies to Improve Physical and Mental Wellbeing. Here's the agenda for today. I will introduce our speaker, Dr. El-Jawahri, and she will spend the next 30 minutes or so giving us her presentation. After the presentation, we will open it up for your questions and comments and end the event with a few announcements. So let me take a second to introduce our speaker, Dr. El-Jawahri. Dr. El-Jawahri is a hematologist-oncologist at Massachusetts General Hospital, Associate Director for the Cancer Outcomes Research and Education Program, Director of the Bone Marrow Transplant Survivorship Program, and Associate Professor of Medicine at Harvard Medical School. Her research interests include investigating patient-reported outcomes, enhancing patient-centered decision-making interventions, and designing supportive care interventions to improve the care of patients with hematologic malignancies, with a special emphasis on patients undergoing stem cell transplantation. We're so lucky to have you here with us today. I've looked over her slides. I know her presentation is going to be so useful for us all. So thank you so much for your time today. And with that, I'll let you go ahead and take it away.
Thanks so much, Katie. Good afternoon, everybody. It's a pleasure to be with you today. And I'd love for this to be interactive, you guys, so feel free. I'll try to keep an eye on the chat for us so that feel free to send me messages. We can take breaks even during the presentation. It's nice to be able to chat together about this. So my hope for today is really to kind of discuss the unmet psychosocial needs of patients with acute myeloid leukemia. And this is something that many of you lived through and have continued to live through. So part of the reason why I'm presenting this is really to talk about how this is a universal experience in many ways, and a lot of these issues are affecting many of our patients and families. And then I'm going to spend the majority of the talk really talking about innovative interventions that we've developed to try to promote coping and helping patients and families deal with this difficult illness, as well as tips for patients and their caregivers, and then we'll spend some time talking about future direction. So we know that patients with acute leukemia, specifically patients with AML, confront a very sudden and life-threatening diagnosis often. This, in many cases, require an urgent need for a 4 to 6 week hospitalization for intensive chemotherapy. Even among patients who are not receiving intensive chemotherapy, many of these patients are hospitalized at the time of diagnosis of leukemia. As a result of the acuity of onset of the illness, the need for hospitalization, these patients experience substantial physical and emotional symptoms throughout the continuum of illness. But there are particular aspects related to this diagnosis that are particularly hard. The abrupt onset of illness, for example, this is one of those things where many of our patients say, that they presented maybe feeling a little bit tired, maybe a little bit of short of breath when they're going a flight of stairs. Not in a million years did they think that they had acute myeloid leukemia. They might have gone to see a primary care doctor, maybe walked into an urgent care clinic, had a CBC checked their blood count, and boom, they received a call. And actually, we now know from the literature that the most common way patients with leukemia find out about their diagnosis is through a phone call, where they're told, gosh, your white count is abnormal, you need to come to the hospital, and you may have leukemia. So this abrupt onset of illness, this urgent need for intervention, coupled with the uncertainty about what the future holds, think about this population that's really abducted from their life and going into social isolating hospitalization. And as a result, there's a complete loss of independence during those early days. And actually, that acute onset, that whole process that I just described, has made AML one of the most traumatic diagnoses in oncology. We know this. AML triggers post-traumatic stress symptoms, clinically significant PTSD symptoms, and it's one of the most traumatic diagnoses that we have in oncology. This is not to minimize the experience of our patients with other type of cancers, but just to say that there is something unique about this early diagnosis that's really hard. And we also know that the stress in this population is high. So this is looking at clinically significant depression symptoms in orange, anxiety symptoms in gray, and PTSD symptoms in blue at the time of diagnosis at 1 month and 3 months, as you can see here. And again, we see that about a third of patients have clinically significant depression and anxiety symptoms at diagnosis, and PTSD, about a third of patients develop PTSD symptoms, clinically significant PTSD symptoms at 3 months. We actually see higher rates of clinically significant PTSD symptoms later on. So nonetheless, a substantial minority of our patients with AML specifically struggle with emotional symptoms related to depression, anxiety, and post-trauma. This is a study that actually kind of asked patients with AML to kind of reflect on the prevalence of certain issues that they're facing, but also how much it's impacting their day-to-day life. And what you see here is that a lot of the psychological distress that I mentioned make it to the list. So fear, anxiety, low mood, loss of control, separation from family and friends, likely related to that hospitalization. But we also see fatigue, pain, difficulty with day-to-day stuff. So these are prevalent issues in our population, but are also impacting day-to-day life. And I think some of my favorite, honestly, studies that really kind of depict the studies that I actually give my medical students to read when they want to learn about what it's like to be a patient with leukemia are actually qualitative studies that are done to talking to patients with leukemia about what it was like for them when they were diagnosed. And I'm just going to share with you some of the quotes from some of these studies. So one patient said, "It just all came to me. It just all comes to a screening halt. I say I got abducted. It wasn't induction," referring to AML induction, "it was abduction." And so this concept of really feeling abducted by this illness is a common theme that we hear from our patients and their families. A second patient said, "You're kind of in shock. I went into the emergency unit. I didn't pack a bag or anything like that, and I wound up being shipped to the hospital. I had no idea I wasn't even going to see my apartment for months. Like, they just picked me up and took my life away." Another patient of ours said that it was like being thrown into a dark cave with no flashlight and no direction, lost and blind. These quotes are incredibly powerful, and they are really depicting just this intensity of that acute traumatic period at the time of diagnosis of this illness. But beyond that, I would say that there are long-term implications to the psychological trauma and this emotional distress that we're talking about. So I think we should care about how people are dealing with all of this just because it's hard, but also we should care about it because there are implications to this initial hospitalization and that initial trauma. Specifically, we know how patients react during that early few days at the time of diagnosis affect their long-term quality of life, their depression and PTSD symptoms later on, as well as potential effect on their healthcare utilization, how often they're hospitalized, and their survival. So clearly, interventions to support our patients reduce their distress at the time of diagnosis are needed and are in fact lacking. I don't need to spend time with this audience to tell you why should we care. I have this slide for a lot of my clinician colleagues who say, well, we're trying to cure the disease, we get patients in and we try to treat the disease. And often our advances in medicine have focused on we should care and define success as helping people survive and getting cured of leukemia. And thankfully, we're doing better and better on that end every day. However, when you talk to patients and families, they say this is not just the end all be all. Yes, survival is absolutely important. And I'd like to be free of disease, and I would like to have an acceptable quality of life. These are metrics of success that our patients and families care about. And so when we think about how we define success, it's not just about getting people through the treatment and curing them, but how do we get them through the treatment and have them remain whole and have a sense of their meaning and their identity after all of this? And so with that as a prelude, I'd like us to spend some time just talking about some interventions and the role of some interventions to help our patients with AML specifically. I'm going to start by talking about the role of palliative care. And I want to start by really addressing any misperceptions about palliative care, because there are a lot of misperceptions equating palliative care with end-of-life care or hospice care. That is not what I'm talking about here. So you guys see this Venn diagram here. When we think about palliative care, we think about an encompassing specialty of clinicians who specialize in complex symptom management, helping patients cope and adapt to their illness. And while end-of-life care and hospice care are part of what we think of as palliative care. A lot of palliative care is actually done early at the time of diagnosis for patients to help them deal with a really difficult illness. And palliative care is much more than hospice or end-of-life care. So I want to start by just defining palliative care, and in fact tell you that studies have shown that integrating these specialty palliative care clinicians who have expertise in symptom management, who have expertise in helping patients cope with their illness and adapt to their illness, in the context of having solid cancer, so lung cancer, GI cancers, from the time of diagnosis, regardless of the prognosis. So some of these patients are going through curative therapy. We know that when these palliative care clinicians see these patients with solid tumors, they improve the patient quality of life, they reduce their psychological distress, they enhance their illness understanding, they promote their adaptive coping, and they help their caregivers. By caregivers, I mean family and friends who are caring for the patient with that diagnosis. So specifically improving caregiver quality of life, caregiver burden, and psychological distress. So we know these benefits. These have been shown in multiple randomized clinical trials that when you integrate a palliative care clinician in the care of patients with solid tumors like lung cancer, you get all of these outcomes. And again, this is not focusing on end-of-life care. This is at the time of diagnosis. When these patients first get diagnosed with cancer, they receive palliative care, and this is what we see. Unfortunately, historically and traditionally, palliative care was just never called to care for patients with leukemia because of this misperception saying, oh, palliative care is just end-of-life care, and in AML, we're trying to cure patients. Well, yes. Is there a potential role for palliative care to help our patients who are getting curative therapy, to get them to feel better, to deal with the distress and the trauma of this diagnosis? And so I'm going to show you data from a randomized clinical trial that we did at 4 different sites: Mass General, Duke, Penn, and Ohio State. We took 160 patients with acute myeloid leukemia, and we randomized these patients to receiving inpatient integrated palliative and leukemia care. So what that meant is basically as soon as the patient is diagnosed with leukemia and is hospitalized to receive intensive chemotherapy, in addition to seeing the leukemia team, they saw a palliative care clinician who was basically with them and saw them at least twice weekly during their inpatient hospitalization, and saw them basically during that intensive induction, but also saw them every time they came back into the hospital. So when they came back for consolidation, they came back for transplant. Anytime they spent any time in the hospital, that palliative care clinician was part of the team, seeing these patients, helping them cope with their illness. The second group was randomized by chance to receive standard leukemia care, where they saw their leukemia clinicians who did everything they could to help support these patients, just like they always do. And what we did is we followed how these patients felt, their quality of life, their distress, and how things went for them. I showed you that these patients experience high level of distress acutely when they're diagnosed and during that initial hospitalization. So let's see what happens. This is looking at week 2 during induction treatment. So I know this is a busy table, but I'm going to actually show you a graphical representation of these data. But basically, this is looking at validated measures to measure quality of life, depression, anxiety symptoms, symptom burden, PTSD symptoms during that acute initial induction hospitalization. What we see is actually the intervention led to improvement in all of these outcomes that were statistically and clinically significant during induction chemotherapy. Let's look at this graphically to make more sense of it. So this is looking at quality of life using the FACT leukemia scale, again, a validated measure of quality of life. Here, just to orient you, higher scores indicate better quality of life. And what you're seeing on the x-axis is timeline. So from the time of diagnosis until about 6 months out, week 24. The intervention group, the people that received palliative care, are in orange. The usual care group is in blue. And what you see here is the patients who received the intervention had improvement in their quality of life, really from diagnosis up to 6 months compared to those in the usual care group. This is looking at anxiety and depression. Again, here the axes are flipped. So higher scores on the y-axis here indicate worse depression, worse anxiety. You see the intervention group is in orange, the usual care group is in blue. And again, you see that patients receiving the palliative care intervention had lower anxiety, lower depression up to 6 months post induction. When we look at post-traumatic stress symptoms, we see the same trend. Look at this. Patients receiving the palliative care intervention had very, very low PTSD symptoms compared to those receiving usual care. And what we learned even further is actually in further studies, like we asked the question, how did this happen? How do palliative care clinicians can make this happen? What we actually learned is that palliative care clinicians really help patients develop adaptive coping strategies. And that change in adaptive coping strategies seems to be the key essential component that really improved patients' quality of life and psychological distress later on. So clearly, palliative care is helping patients cope and adapt to their illness in a different way than what we do as leukemia clinicians. That is really helping these patients deal with their distress and the difficulty with this illness. So palliative care is not the answer for everything, but I think one of the things that we learned from this study is how do we help patients with leukemia? We asked ourselves, what are the lessons learned from how these palliative care clinicians are helping these patients? And then we asked ourselves, can we translate these lessons from the palliative care intervention to digital health intervention? The reason to think about digital health intervention, because as many of you know, there is a tremendous shortage of palliative care clinicians, mental health clinicians, social workers, psychologists, all those supportive care clinicians that have expertise in helping patients cope with their illness. They're not around a lot of the time. There isn't enough of them to take care of all of our patients with AML. So we asked the question, can we learn from this? Can we transition this to a digital intervention that help patients by normalizing and validating that acute diagnosis, helping them manage the expectation and make sense of the senseless hospitalization, promote their adaptive coping, and promote their self-care during the hospital stay. The reason we focused on a digital health intervention is because we thought patients are stuck during a prolonged hospitalization. So we really focused in this particular study that I'm going to show you on patients who are hospitalized during induction chemotherapy. We hear from patients all the time, I'm stuck, what can I do? And so giving them a sense of control and giving them something to do to help their situation by engaging in a digital health app that could help address their issues might be a really good way to help them cope with all of this. It's also a very patient-centered approach. So it allows patients to engage with the app when they want, get the information they want. You know, we hear from a lot of patients and their families, gosh, the first 3 days, I hear so much. I'm so overwhelmed by the amount of information I receive. Yet after that, there's kind of a vacuum of information. And some patients want a lot of information to begin with. Some people want little information, want to kind of go day by day and learn day by day. And so by having a digital health app, patients have control and agency in terms of how they want to use their time and how they want to actually engage with the app. So let me show you some data on this digital health app that really translated a lot of the lessons we learned from the palliative care intervention. The app is called Dreamland. Again, we took 60 patients. This was a very proof of concept study. So we took 60 patients with AML. We were grateful for them to participate in the study really at the time of diagnosis, within 72 hours of being admitted to the hospital. And patients were randomized to receiving Dreamland, which I'm going to show you some screenshots of. This is the digital app for patients with acute myeloid leukemia. And we said, you know, there are certain modules for this app. You can complete them during a hospitalization, complete them at your own pace. The other half were randomized to usual care, where again, they received all the supportive care that they usually get as part of their leukemia care. And honestly, the first question we asked is feasibility. Can we get patients with AML to really engage with an app? You know, is this an appropriate way to relay information when patients are going through such a hard time? And can we improve some of their outcomes, their quality of life, mood, symptom, and self-efficacy? So what does Dreamland have? Well, Dreamland has modules or sections that are focused on helping patients, support patients, so really what we call supportive psychotherapy, kind of validating that initial shock, the loss of control, the abrupt life transition that's happening. There's a lot of education about the illness, helping patients understand what's happening during the hospital stay, and also projecting about the future, what to expect in the future. And then we really have some very basic cognitive-based coping to promote effective coping for this population, but also help patients care for themselves. What are some strategies that they can help really promote their own well-being and self-care? So let me show you a couple of screenshots from Dreamland. This is Dreamland. It's set up as a cartoony place outside of the hospital. We chose sort of a nature theme. I'll show you some of our initial apps. We actually struggled early on. Building these apps is really expensive. And so in order to make this more adult-like, you have to spend a lot of money on graphics. So early on, we really kind of stuck with the basic to try to see if this is even feasible for our patients. But it's set up as a journey. The journey is set up in such a way that patients kind of navigate through that 4-week to 6-week hospitalization. And each module is labeled. So you kind of go through the content for week 1, you go through the content for week 2. Each one of these modules takes about 15 minutes to complete. So they're not that long. It's not a lot of content, but it's modular based information that people can get. The goal is to get home. That's what people are most excited about, is trying to get through this hospital stay and having a final destination of getting home. Patients get to choose an avatar for themselves, kind of personalize this a little bit. And then there's a medical guide, a doctor who's kind of walking them through the app. Information is conveyed in the app via these text bubbles and audio. So the doctor is actually talking to them, giving them information about what to expect during the hospital stay, what is happening here. So they get to build a relationship with this avatar of a doctor, because again, they get to know that person, they hear their voice, and it's a constant presence throughout the hospital stay. One of the favorite things that people like about Dreamland is sort of the roadmap. A lot of times people feel lost during that initial hospitalization. So we provide some really basic information on, hey, what's happening? Where am I? And if you click on any of these little boxes, you get more information about what's happening in day 14, what happens on day 15 to 20, what happens when I get home. And there's a little bit of gamification that we built in Dreamland, mainly to reinforce learning and make this not boring, right? So if I give you a lot of information through the app and you're just kind of listening, I lose your attention. So part of what we try to do is incorporate these simple games, not so much to play the game, but to really reinforce the learning. So for example, this is the train exercise where the goal is to kind of help people rebuild the roadmap that they just saw. So again, reinforcing the learning about what's happening during the course of illness. Probably the most popular aspect of the app is videos from patients who've gone through this, right? Hearing from someone who's lived through this experience, what helped them get through, one, validates the people who are going through this, but also gives them help for what it's like to be at the other end of after all of this. And again, there are a couple of additional games that we have here. I'm just kind of showing you. This is the paper toss game where we try to reinforce learning about psychotherapy and cognition. So we try to help people kind of understand the connection between their thoughts, emotions, physical sensations, and behaviors. Those are kind of principles of cognitive behavioral therapy. And in the process, then we play a game or an exercise to really help them understand, sort of reinforce that content. This is my favorite game. This is the whack-a-mole game. In this game, the idea here is to really push away or whack judgmental thoughts. It's part of our exercise when we talk about mindfulness and, you know, being present with your thoughts without judgment. There's the mindfulness diaphragmatic breathing that's involved and included. So just to give you kind of a flavor of the app. So what did we learn? Well, first of all, we learned that, you know, a majority of patients actually not only got through the app, but completed the app. In fact, 50% completed all required modules. And the people who didn't complete it, the primary reason actually they didn't complete it is because they got too sick. They were in the ICU. So our level of engagement was actually really high for mobile apps. Just to give you a sense, you know, about 30% of participants in other studies kind of get through digital health interventions. You can see that the amount of time spent in apps is not that much. So people use Dreamland on average about 1 hour and 8 minutes during their entire hospital stay. So it's not a long time with the app. And as I mentioned, the primary reason people didn't complete it is when unfortunately they were too sick. So this table should look actually pretty familiar to the table I showed you earlier. Again, it's a busy table, but what I want to show you here is that across all of these metrics, quality of life, anxiety, depression symptoms that I showed you earlier, here again, At day 20, sort of in that nadir when people are struggling the most during the hospital stay, we see that patients receiving Greenland have better quality of life, lower anxiety and depression symptoms, similar to what we saw with a palliative care intervention. All of these were significant both clinically and statistically. I'm just going to show you some feedback from patients who've gone through this. So I'm just going to read you a couple of quotes, but overall, overwhelming feedback was very positive about this for people who used it. And one of the patients said to us, "I don't know how my wife and I could have gotten through this admission without Dreamland. This was the most difficult times of our lives. When I signed up for the study, I never thought that this app will be so important to me. I use the meditation exercise every night to fall asleep." Another patient shared how they liked the information aspect. "I was reading a lot of wrong information on the internet. I needed to know what to expect. It was helpful to have a credible source for information." So this is just the beginning, right? And I want to say I've spent a lot of time talking about patients, but we should just acknowledge that this is an illness that hits the entire family and friends and loved ones of patients. And we have such immense caregiver needs. Caregivers of patients with AML require a lot of support during the illness course. They also have tremendous burden. And really, one of the key elements that we've learned is when, if you think about it, caregivers actually provide the majority of care for patients with cancer, right? Most of the care is not happening with your clinicians, it's actually happening at home. And so what we've learned is really when we focus on the caregiver and address the caregiver needs, we can improve both patient outcomes and caregiver outcomes. So I just want to put a plug that we are working on this. Our sort of next step is developing this caregiver app that's really focused on caregivers of patients with AML. I'm showing you just one or two screenshots of this because this is early on, but you can see that now that we were able to develop a little bit of content and experience, this looks very different. This looks very adult-like, less cartoony. The graphics are better. We're able to actually spend more money. You can kind of see that it looks very different. But again, the idea is to mirror what we created for the patient app to a caregiver-specific app to address their needs. So with that, I'm going to spend a couple of minutes just talking about tips for patients and caregivers. I have to say that this is based on my own clinical experience caring for patients with AML, but also what we've learned from the psychological literature about what I think is really, really important as patients and families deal with this. I think the first thing to say that it is okay and totally expected to feel overwhelmed. Sometimes we scare ourselves when we feel overwhelmed and feel anxious and feel worried about what's happening. And we should just say that's a universal experience. Almost everybody facing that diagnosis feels overwhelmed at times. And it's okay to acknowledge and normalize those feelings for us and not to think of them as something that's wrong and or problematic. The second thing I would say is stop Googling. Every time I Google AML, I find wrong information on the internet. And really ask your doctors for a trusted source of information. Not to say, knowledge is sometimes power, or for some of us, reading and learning about our illness is really important, but go to the right source, go to a credible source of information, because a lot of the information out there is really not helpful and it's not accurate. And then the third thing I would say is ask for additional resources. I've shown you that palliative care can help. I suspect that psychology, social work can help. It is really important to focus on your mental well-being. So advocate for yourself. Ask for the help that you need during hospitalization. I think our culture is changing, but for a long time, our culture had misperceptions about how do we take care of our mental health, and it was a sign of weakness that you even ask for your help in that domain. And I just argue it's actually the exact opposite. When we're able to pay attention to our mental well-being, how we're coping and dealing with an illness is actually how we're able to breed resilience and overcome challenges and obstacles. The other thing is to learn how to best mobilize your social support. This is a universal experience too. Often when patients are diagnosed, everybody mobilizes, right? Everybody wants to be there. Everybody wants to help. Everybody is offering a certain type of help, often social support, or sending you a lot of soup. That's the other thing. A lot of soup comes to the home, right? But the reality is this is an illness that takes time. It's not the first week, it's not the second week, it's 3-4 months later that often we need help. So be strategic. Think about your social support network and tell people, be sort of very communicative. I really appreciate all the soups I'm getting today. And what I really need you is probably a little bit later, and kind of create a schedule. Think with your caregiver about who do I want to be my support system early on? Who do I want my support system to be a month from now, 3 months from now, and build that map for you with mobilizing your social support. And often people provide one certain type of support. So often people provide emotional support, but sometimes we need practical things, right? We need somebody to go to the grocery store and get us groceries. And so being able to communicate with your social support network and saying, hey, I really appreciate all the emotional support you're giving me. And what I need right now is somebody to pick the kids up from school, right? So really being able to mobilize that social support network is helpful. And then I think the other piece is not shying away from hard questions. Sometimes we have questions about, what does this all mean? What's the likelihood that I'm going to live and get through this? You know, what does the future look for me and my family? And sometimes we shy away from asking these questions from our clinicians. And I would say, when we do that, often they don't go away. These questions are the elephants in the room that we're thinking about each and every day, us and our families, but we're suffering alone and not getting the answers that we need. So prepare your questions for your doctors, and know that doctors are more than willing to engage in these conversations. And then the last thing I'll say is, you know, when we talk about coping is such a complicated construct, but the reality is we all cope, right? We all cope every day with everyday challenges in our lives. We cope when the bus comes late. We cope when we fail an exam. We cope when we get AML. And so you have coping strategies that you've built over the years, and those coping strategies don't go away all of a sudden when you're faced with an illness. In fact, those are the very coping strategies that actually help us promote resilience. So take a step back, take a deep breath, and think about what has helped you get through difficult days in the past. It may not be AML, but it could be something else, and those coping strategies might be really relevant here. And the last thing I want to say is to talk a little bit about future directions. And when it comes to future directions, I think I want us to kind of think about, how do we kind of take a step back, think about all the information I showed you, and ask ourselves, how do we scale and disseminate successful interventions like this to reduce the stress and improve quality of life in patients with AML? You know, I'll give you a sense. For our Dreamland app, we did this pilot study where we took that app to the FDA and said, we would love for this to be approved as a prescription therapeutic for patients with AML, so that a clinician caring for a patient with AML in the hospital could actually prescribe that, just like we prescribe drugs for AML, right? And so patients can actually get it. And the FDA agreed. They said, that sounds great. Why don't you guys do a larger scale study, prove the efficacy of this across care settings in a bigger population, and we will give it a label so that patients with AML can have access to it, right? We want to be able to support getting this to patients and families. We need to demonstrate the long-term benefits. I showed you a lot of effects of these interventions during the acute hospital stay, but we want to see that this leads to actually better outcomes for our patients and families. And the last piece I'd say is, you know, understanding active components of successful interventions is really key. So knowing why palliative care improve outcomes, or why digital health interventions improve outcomes, can actually really help us understand, are there active components in these interventions that we can take and integrate into our practice? I'll give you an example. We are now doing a very large scale 20-site study where we actually are randomizing sites to deliver two types of care. One is specialty palliative care, the palliative care model that I shared with you earlier. But the other way was actually to take the lessons we learned on how palliative care clinicians care for patients with AML, and actually train leukemia clinicians, leukemia doctors, leukemia nurse practitioners, leukemia nurses, to integrate these palliative care components and principles in their practice. That's what I'm calling primary palliative care here, where the leukemia team is integrating these palliative care principles in their practice. And we're actually seeing if that can achieve the same goal. Again, not to say that we want to replace all the palliative care, specialty palliative care clinicians in the world, but it's a way to scale and disseminate, because often there are going to be centers that don't have access to palliative care clinicians. And man, if we can train leukemia clinicians to help patients cope and adapt to their illness better, maybe we can improve all of these outcomes that I showed you earlier. So the two models we're kind of checking is primary palliative care, again, where the patient comes into the hospital, see a leukemia clinician who is trained in palliative care to help the patient cope and deal with their illness, versus the model that we tested earlier, specialty palliative care, where again, the patient comes in, is seen by a leukemia doctor and a palliative care doctor to help them through it. This is just an example of how we can take lessons learned and apply them to really help patients and families. And so with that, I'm happy to end here and open it up to questions. And I'm going to actually stop sharing so we can actually see each other as well.
Thank you so much, Dr. El-Jawahri. That was excellent. You provided such a great background and overview of your work, which is just so important and so much needed. I talk to patients all the time who have gone through these hospitalizations, and they have told me that they feel half of them has been neglected, and that the whole focus is on the physical being, the physical side of treatment, and the mental side is overlooked. So it's something that's so much needed, and we hear every day at HealthTree. So thank you for all the work that you do. I'd love to open it up for questions, comments, whether you want to type something in the chat or raise your hand. We have plenty of time to have a really nice discussion. And something I'd like to add, maybe that you can type in the chat box. I'd like for this to be a time where we can all learn from one another in our own personal experiences. So if you have any tips for coping strategies that you have felt have been successful for you personally during your journey, I think we can help each other out by sharing those and talking about them. And even if you've had struggles, if there's things that you have struggled with through your journey that you feel might need a suggestion for a coping strategy that one of us might be able to provide for you, I'd love for you to share that as well.
Katie,
so
I will just say that, you know, I really do appreciate that point about tips from patients and families. One thing I didn't show you that is in Dreamland, as well as some of our other apps, is actually that we ask patients who've gone through the app to give tips for others who've gone through this experience. And it's incredibly powerful, right? Because, you know, there's nothing like living through this experience that really can help you learn what the good lessons and the bad lessons about how to deal with all of this. So I really do think those are important lessons, and often neglected, and are not actually the ones that we're talking about in our clinical practice, but are really, really important.
Absolutely. I think AML is such a unique experience that you need to connect with others who have gone through the AML specific journey. And that can be really hard to find. So anywhere you can find a connection with someone else who's been through it is really important. And a huge reason why we host these meetings, why we're even as a foundation considering a coach program. We do it in our myeloma division, but it's one-on-one mentorship support between a coach and a coachee. So for anybody maybe looking for that type of resource, we're hoping to maybe have that available to you in the next few months. I see some good things coming up in the chat. So Juliet's asking if the Dreamland app is available to anyone currently.
Yes. So Dreamland is going through an FDA registration trial right now. The trial is going to be open at Mass General, Fred Hutch, in Seattle, UCLA, Duke, and there's one more, UCLA, Duke, and Cleveland Clinic. However, so that trial is going to allow us to really be able to prescribe Dreamland to everybody, is our hope. However, I've had people request access to Dreamland, and I'm happy to provide access to Dreamland off clinical trials. So you just need to reach out to me, and I'm happy to do that, Juliet.
And Juliet, we can provide, we can create the connection between you and each other, so we can make that happen. She also mentions that this is a journal calling creative journaling session that HealthTree kind of collaborated with an AML patient who created this workshop for creative writing and journaling, and Juliet participated in and received a lot of benefit from that. So probably hinting at the fact that journaling can be a very effective coping mechanism that's useful for a lot of people. Steve, I see your hand is raised. I'll let you come off mute.
Thank you. Yeah, I raised it before I decided which of my questions I want to ask. I noticed you cited some of the work by Tom LeBlanc, and what I remember from one of his pieces of research is that the more AML patients know about their prognosis, the worse their psychological well-being, which I think is probably specific to AML and maybe a few other diseases, but it was a very interesting finding. And it kind of dovetailed with my journey in that I somehow managed to avoid hearing any news about my prognosis. I learned a lot about my treatment and my disease, but they didn't tell me and I didn't ask about the prognosis. And it turns out by accident or chance or whatever, I think that was a really healthy thing for me to not know that until I needed to make a decision about transplant. And then they said, there's this fork in the road, that fork, here's what you need to know. But I was intrigued by one of the graphs you showed. I think it was comparing the palliative care experimental group with the control group. And the lines were different, but they sort of went parallel with each other until weeks 12 to 24. And then the control group seemed to get worse and the experimental group seemed to get better. There's a big divergence in that 12 to 24 week period. Am I reading that accurately? And do you have any idea why that would be the case?
You are. I think you're actually specifically talking. So great comments, Steve. I think there's a couple of things to talk about there. So we'll get back to the prognostic understanding piece. It's actually specifically the graph that you're mentioning is PTSD symptoms. So PTSD develops later on, right? Often PTSD actually gets worse over time. So that's exactly what you're seeing. You're seeing a buffering of PTSD symptoms in the palliative care group because at least the hypothesis is you're intervening during the acute trauma and reducing that acute trauma on these patients. And as a result, getting less PTSD rate later on. And that's why you're seeing the divergence later on. To your comment about understanding prognosis, so that's actually a finding that we've replicated across multiple populations. Tom and I did it in leukemia, we did it in the stem cell transplant population, but we also did it in lung and GI cancer. This idea, if you know more about your prognosis, people who understand that they have a terminal illness or feel like they have a worse prognosis, have worse psychological distress and lower quality of life. That's been sort of the findings. I will say, kind of taking a step back, and if you guys think about this, it's actually, the story is more complicated than that simple association. So, and it makes sense, right? You guys think about it. If like you go see a doctor and the doctor says to you, hey, you're going to die from your leukemia, are you going to feel pretty happy that day? Are we all not going to be depressed? Who's not going to be depressed when they hear that news, right? It's a very depressing news. It's common sense. It's intuitive. If you're hearing about a bad prognosis, that's really hard news. And it's associated with psychological distress, and it should lead to a quality of life impairment. The issue is, in medicine, we do a lot of these prognostic disclosures, right? Where we tell people what these things are, or they read about them on the internet. Yet we don't help patients process that information, figure out how to deal with it. For some people, that information is really helpful and informative, and they need it to plan their lives, to move their daughter's wedding ahead of time because they really want to be there, right? But if we just throw information at people without providing them with the capacity to process, adapt, learn how to deal with that information, of course it causes psychological distress. And so, Steve, what we've learned from the literature is actually how people cope with their prognosis is the key aspect to that. That when patients are provided with a holding environment where that information is first conveyed in a compassionate ways, but also help patients actually leverage that information to their benefit in terms of how to think about the future, makes a big difference. You actually see improvement in quality of life and reduction in psychological distress. So again, it makes intuitive sense that we see this, but I do think it's a really critical aspect to thinking about. It's not to say that not knowing your illness and not knowing prognosis is a good thing, but for some people, Steve, that's probably a good thing early on, to your point, right? If you don't need to make any decisions that really impact anything, and you're about to, you're entering this period, as you mentioned, you kind of, until you got to the transplant fork, you're like, I need to live. I need to get through this part. At that point, illness and prognostic information for you would have not helped you at all, right? You didn't need it to make any informed decisions. So thinking about when and why are we disclosing information, how to support patients and families with that information is really the key.
Excellent. That was great. I have a comment here from Susan, who wishes this was available last year. She's suffered from PTSD. Mental health professionals are hard to find, as we all are aware. Her biggest piece of advice is to stay off social media and to stay as physically active as possible. So those are great comments, Susan. And it kind of piggybacks off of what you were saying in terms of this battle between trying to prioritize your mental health, but also to become educated and empowered. So it's knowing where to look, what's reputable, and potentially taking what you read on your own and having an informed discussion with a healthcare professional to help kind of weigh that balance out. It's really important. I see Stephen Pat. Hello, I see your hands raised.
Hey there. Yeah, we haven't totally discussed this while we were sitting here, but our oncologist is Tom LeBlanc.
We're very lucky.
And this question about prognosis, right? So we asked at our first sitting with him some questions about that, and he skillfully turned it back on a discussion about individual responses to therapy and so on and so forth. It also turned into a discussion about what do I do to engage with people. And looking back on it, I think this was a really smart guy. And my answer is I play piano. I play at Duke, around the Duke system and so on and so forth. And do you know that by the time I arrived in the unit for my first 37-day stay, people were like, well, you could have a keyboard here.
You did.
And I did,
did.
yeah.
Second day.
And that was my way of engaging with, socially, with patients and staff, nurses, and so on and so forth. It became very, very powerful. And actually, my keyboard is stored up there currently
every
for my
time he
next
visits.
visit, which is probably next week.
Yeah.
But I think the lesson applies to everyone. So the guy next to me in my last stay was an Ohio State football fan. And so what I observed among all the people in that unit was that there is a tendency in all of us, me included, to turn inward, especially during the rough chemo. And, it renders you just so quiet. It takes energy to converse or to do anything, get out of bed, to eat lunch, whatever it is. The social engagement piece is the one, and exercise. Exercise, number one, walking. But number two is engaging with others. And my belief is that every person has something that they can't avoid coming alive to chat about and to interact about. The guy next to me, it was definitely Ohio State, but the guy across the way was country music.
Yeah.
But anyway, I think that obviously depression, all that kind of thing have to be dealt with on the psychological dimension, but social engagement is something that each and every one of us has the ability to take a step in one direction or the other, either to let the person know that we're talking to, this is my jam, this is my thing here, or to find out theirs. And there's usually an intersection with some folks. Priceless. And to see those people then when I'm walking around,
Remember,
exercise. Yeah.
Thanks so much, Stephen Pat, for sharing. Thank you so much for sharing. That's incredibly helpful. And well, a couple of things. One is I'm a Wolverine fan, so I'm not going to like your Ohio State guy, but that's okay. Number two, Tom is I always call Tom my work husband, but I will tell you something about Tom. Tom is a palliative care clinician by training. So he has both leukemia and palliative care training. So I'm sure he masterfully walked you through that conversation and many other conversations. And again, it's probably an odd thing because most leukemia clinicians are not trained in palliative care, but I do think his palliative care skills probably come in incredibly handy in that difficult job. And I agree with you so completely. I didn't actually talk about some of the data on exercise and how exercise in itself, I mean, what I love about what you said, Steve, is you've kind of pointed out all the different coping strategies that people have that are unique to them. For you, it's playing the piano. For the guy next door, it's Ohio State. It's the country music. It's exercising. That's what I mean by really looking inward and finding out what helps you cope with difficult times, right? And I mean, what I mean by that is difficult times like having the flu, because those things also apply when you have leukemia and they can help you deal with difficult times. But just another word about exercise, we just have a lot of data to suggest that exercise during the hospital stay and after the hospital stay is not only helpful for physical recovery, but mental well-being. So and many of you in the chat have mentioned physical activity, yoga, all these forms of exercise are actually a form of meditation, but they help really engage your physical and mental well-being.
Great. I had a thought that came up, or question actually. So I've found that a lot of the conversation when it comes to palliative care centers around the newly diagnosed person, induction. And I'm wondering if palliative care is integrated later on, potentially. How would a patient seek out palliative care who's further down the line in terms of treatment? Is that something they should ask for if they feel they need it?
Yeah, absolutely, Katie. I mean, I think for AML, what we've learned is integrating early and longitudinally is helpful. So when we get these patients involved, when we get palliative care clinicians involved in the care of these patients early, they follow them throughout the hospital course and throughout the continuum of their illness. And for many of our patients, they were lucky and they're cured, and the palliative care clinicians are celebrating that cure with them. For those who are less fortunate, where the leukemia comes back, palliative care plays a key role in that. If you remember what I chatted about to Steve's point, there is a process of adapting to a potentially life-threatening diagnosis and prognosis, right? And that adaptation and how to cope, how do we actually, I think the key sentence I say, how do you live well while acknowledging the possibility of dying? Man, that's an amazing skill to have. We should all have it, by the way. It's a really great skill for anybody dealing with a difficult illness or not, right? If you're living every day thinking that you're dying, you're not going to enjoy life, right? So how do we live well while acknowledge the possibility of dying? We're all going to die at one point. That skill set is what palliative care is probably the most expert in, is helping people make meaning of a really difficult situation. So I would argue, Katie, that historically and traditionally, palliative care was integrated very late in the illness course, actually in the last week of life. It's like almost synonymous with hospice at that time. But this is the benefit of integrating early, and early, you can define early in many different ways. But when palliative care clinicians are able to build connections and know these patients over time, they can help them adapt and cope to that difficulty and that reality if the outcome is less fortunate. And yes, absolutely, I would say everybody who has relapsed leukemia absolutely should ask for a palliative care consult. If leukemia has come back, they should absolutely ask for a palliative care consult, because we know they're incredibly helpful. Again, they're offering an extra layer of support. They're not substituting anybody. They're really an extra layer of support on top of your leukemia team.
Great, thank you. So I think we'll end on this. I see Maureen has her hand raised, so go ahead and come off mute, Maureen.
So just real quick following on that. So I was AML relapsed stem cell transplant of July of 2019. March of 2020, I was just getting a little, you can go out and do something, and the world shut down. So I was a little mad, angry. I'm like, okay, what's a couple months? Well, it's been over a year. So I've been struggling as far as, so I've basically been quarantining since March of 2018. I've gone out and do a few things, but definitely struggling emotionally, mentally, as far as going out and getting back into the world. Am I too late to get help? I mean, I've seen a couple counselors. I don't think they get it. A lot
Maureen, no such thing as too late. No such thing as too late. You actually need it more now. You know, so I apologize for interrupting you, but really, really no reason to think too late. And I absolutely would urge you to get as much support as possible. Meet with I think the best people who can understand your lived experience are probably actually people who are integrated in the transplant or leukemia team. So a social worker who's integrated in the transplant or leukemia team, who knows what it's like to be, in isolation and living in a bubble for that long, right? Any of us would lose our mind if we're doing that, right?
Yeah, so it's just getting, a lot of people, I know they're busy, and getting phone calls back has been a huge struggle. And finding answers. It's been really crazy.
I can't even imagine. And honestly, Maureen, it's the experience. So I'm a transplant oncologist. So I do stem cell transplant. I do mostly stem cell transplant for leukemia. But that's the number one thing that the pandemic has really, there have been positive things for patients because now everybody wears a mask when they're outside. So they're not the only one who's wearing a mask.
Right.
But really, honestly, that isolation is so difficult, right? Because you're trying to do all the right things. You're trying to keep yourself healthy after going through such an incredibly difficult experience, but you're not alone. This is something that every patient who've gone through a stem cell transplant struggle with. And you're at a point, Maureen, based on what you told me in terms of time course, where some of these things you actually can be a little bit more free and liberal about. And so I would really encourage you to talk to your transplant team, because we got really good treatments for COVID now, you guys. And so things are different than they were a year ago. And you may not need to live in bubble, and you may need to be able to actually do a little bit more to allow yourself to have some acceptable quality of life.
Thank you.
Great. This was an excellent discussion, and we're right at time. So we'll go ahead and wrap up. Thank you so much, Dr. El-Jawahri, for being here today. This was just so excellent. I'd like to take a second to mention our next Adult AML Chapter event, which will be on October 24th from 3 to 4 p.m. Eastern. We'll be joined by Dr. Alice Mims, who's an AML expert from the James Cancer Center at Ohio State University. She'll speak to us about venetoclax and venetoclax combinations. So the registration page for this event will be up soon, and you can find it at the link here on the slide. Once again, thank you to our HealthTree Community for AML event sponsors, Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. And thank you for helping us to build a strong HealthTree community for AML. I appreciate you all. Hope you have a great rest of your day, and hope to see you again in October.